All righty. So we're going to be talking about prevention and we're going to talk about health and genetics. And I just quickly want to make sure that I pulled up the right one. I do. Let's start the slideshow. Alrighty, I'm going to shrink us all down. I have you guys like super micronized on my right side of my screen. So you need to speak up if you have a question, because if you're raising your hand, I have you micronized and I can't see you. All right. So please don't hesitate, but speak up. All right. Okay, health and prevention, and we're going to talk about genetics. So every one of us is a nurse, and all of us have an understanding and a perception of health and what disease is. But when you try to put this into a contextual component, it gets a little bit easier if you think about health and disease, if you think of it as an iceberg. And the iceberg theory actually correlates really, really well into this particular course because disease management sits up here at the top. And this is where we do things to address the symptoms. And we negate the part that's underwater, which is the bigger part, which is the health. And there are so many things related to health that we could do, but we don't do because nobody takes the time to engage the patient, use those motivational interviewing skills, and help guide that patient into self management and have them understand that we as health professionals, we can only do so much. So basically, maybe 20% of the care we do, and 80% is what they do. So they hold a bigger share of the basket of their own health determinant versus us in the healthcare field. So as part of the iceberg theory, we've got a lot related to metabolic function, but underlying the metabolics is our lifestyle choices, and the socioeconomic components that go along with it, and the social determinants. This body that we live in, this vessel, actually was designed for it to be self-repairing. It's awesome. We can self-repair and we don't need anybody to help us. But people don't do what they're supposed to do to allow that body to do those repairs appropriately. And because they don't engage in those practices, we get disease. We have to allow that body to rebuild itself. Whoops, backwards. We need that body to rebuild itself. And how it rebuilds itself is through how we nourish it. The choices we make in lifestyle, so our stress management, our smoking, our alcohol use, our drug use, including our pharmaceuticals that we have out there, my exercise activity, getting my body moving versus keeping my body stagnant, and then looking to try to get that body back into a balance between the proper nutrients that can control inflammatory processes or promote them, and to help that body utilize both the chemical processes associated with nutrition and those associated with exercise to chemically get the body back into the positive metabolic state and detoxify it. But if you do a reflection and just think about what you see people doing and what you see them not doing, is their diets are not really that great. Their lifestyles may be okay, but there's improvement. And if you ask them about what exercise, it depends upon what age group you're talking to and what they say or not say. We use medications to control symptoms. They do not cure diseases. Now, when I say that, let's think about cancer. We use drugs to eradicate cancer, to kill cells. That's what we're doing. We're using chemicals to kill our body cells. We're killing the cancer cells at the same time we're killing normal cells. We're doing harm. And the goal is that with cancer, we're able to get the healthy cells to regrow much quicker and overtake the cancer cells. And if we can't, well, then we fail. But if we're able to, then the person is left dealing with the body's harm that came from cancer therapy. And we work with that with nutrition, we work with it with mental health, we work with it with medications to control symptoms, to support that body, to rebuild, repair itself, and get them into that remission state. And then working with them, we try to keep them in remission and keep the stimulus that caused their cancer in the first place from reoccurring if we possibly can. Those stimuli come from the diet, the stress, the physical activity, and what people do and do not do. And we're going to talk more about that. So when we talk about health promotion, it's not just a one-time fix. It's not a one-time think about it thing. And in actuality, health promotion has been going back all the way back to the Civil War and Florence Nightingale. And almost every national nursing entity has health promotion as part of its mission and part of what they want us to be able to do as nurse practitioners. The IOM, this is their statement from 2010. They're working on a new statement going on right now. This is not going to change. It's actually going to get more in depth related to nurse practitioners and what we need to do to help patients be healthy, stay healthy, and get healthy. And our nursing essentials just changed. And these essentials are from 2011. The 2021 ones just came out. I didn't have a copy, but I can tell you that these essentials that I have listed here, they haven't changed. But what has changed is they are now focusing more on nurse practitioners being able to develop plans of care that keep people healthy, that address health as a first entity and include health and promoting that health as part of disease care plans. So in other words, I have congestive heart failure and you're going to give me a great drug called Lasix and make sure my heart rate doesn't get too big and give me some metoprolol and make me happy. But you're also going to be giving me education on nutrition. You're going to be teaching me about fats. You're going to be teaching me about carbs. We already know about the salt, but you're going to go a little bit more in depth. And now you're going to bring in exercise and how exercise and the anti-inflammatory properties can actually help my heart heal. And this is where they're going and what they want us to start doing as nurse practitioners. The cool thing is our program here at CU, we're already teaching you to do what they're saying we have to start doing. So we don't have to make a lot of changes in this program because we're already doing it. There's quite a few interrelationships. This is my model, and this is based upon my 20 some odd years of being a nurse practitioner and what I believe is involved in a true relationship with a patient for their promotion of their health. So the big aspects of it are on the outside with the bigger rings. Our job as nurse practitioners is one, to get a foundation and understanding of how do we help people change. In order for us to help people change, we ourselves have to understand the barriers that people encounter in change because we ourselves are patients just like those we care for. The same things that affect us, the same things that our brains think, the same barriers that we put up are the same barriers our patients put up. So we are our own model of it works and it doesn't work. We're also our own barriers to helping patients because we intentionally will hold back on elements that we don't agree with, that we don't find value with, that we don't clearly understand. And we won't speak of those because we don't want that patient to think, well, they don't know what they're talking about. Well, we don't if we don't understand it. So looking at this model, the things that underlie the interrelationship and the association with health, we know about nutrition, exercise, and we're going into the pathophys, not just, hey, Kim, you got to get out there and work 50 minutes 5 times a week. Well, yippee for Kim. How is she supposed to understand by doing that what it's going to do to her body and help her? Then we have education literacy, and we just talked about that. And you have really well spoken to that when we were in conference today. This is us understanding people. We use theory to do that. And we're going to get into theories a little bit later on into this course. But people do the craziest things. And it can be very frustrating for us as nurse practitioners. We're trying to get people to make changes, to engage, to have self-responsibility, and they don't do it. And we can get ticky with them. But instead of getting ticky, if we can understand the why are they not doing it? That keeps us from getting frustrated, but it also provides us with tools to help us navigate around those barriers that they put up and work with the motivational component of it. So there's a lot of theories out there. Some of you had been talking in previously about ORM, self-care deficit theory, which is a theory that I am ingrained in. And it's a great theory because it tells me where my place is, and it tells me what my role is when I'm working with patients. So I use that theory quite a lot. It also helps me understand how I can work with a patient to understand them and motivate them. It also helps me understand some of the genetics and the life cycle. Don't forget that personal experiences sit tightly in the memory, and people have failed several times and they believe that failure is the way it always is, and therefore they're going to be unsuccessful. Then we have to look at the health disparities in our social determinants. Are people able to afford this? Do they have access to it? Culturally, is it acceptable for them to be engaged in this? Is it going to cause them problems? And then we have to bring in technology, and technology is blowing up right now. And almost I can make informatics its own large ring. In the center is the little bit of what we have is drugs. So if we work on the outside and work with all these elements, when we get to the inside, we have drugs we can use. But if we work on the outside, drugs are the last thing we will turn to if we're able to work with these elements on the outside first. And then overlapping all of this is working with the individual, collaborating with them, learning and understanding what they feel is important. Are they able to do it? It's a negotiation. And you learn the art of negotiation with your patient, and then how you become that coach. And literally in this course, I'm going to be helping you become health coaches through the dynamics of interrelationship building and the interventions and the discussions that occur with the patient related to them. There's quite a few definitions out there of health promotion. You have your own a definition of health promotion, and nobody's definition is the same, but they're close and they're similar. So this one's from Tones from 1985, which I thought was pretty darn good. Any intervention designed to foster health is health promotion. Any intervention. Is it always about intervention? And does intervention always change? In some ways, yes. Because when we're starting to work with an individual and we want to work with them in a motivational way, we're asking them to begin to think differently, to eye something differently, to try something differently. So that is change. The one by Pender sticks with me, and I love Pender. I don't use just one model to help guide how I work with patients. I use 3 different models. So I use Orem, I use Pender, and I use Prochaska's change theory. And those 3 guide me in working with patients and keeping me from literally not wanting to be a nurse practitioner, because nobody's doing anything I'm telling them to do to try to help themselves. So those keep me all based. But this one I think is really good. Increasing the level of well-being. And well-being is defined by the patient and not us. And the self-actualization of a given individual or group. And that self-actualization is their abilities. Are they able to do it or not? So coupling their capabilities with what level of health, well-being they want to get to. Now, it's important to understand that health promotion does not, in the sense, mean marketing or selling anything. It's about optimizing the internal aspects that make my body run in harmony and homeostasis. So my CMPs, my CBC, my A1C, my renal function, my liver, my heart rate, my digestive tract, every system is working in harmony with no symptoms. That is health promotion. So the medical model, and we as nurse practitioners are working in a provider role, and that provider role is one that originated within the medical model. There are many sites in which we as nurse practitioners adapt our belief and value system into that model of care because it is overseen and run through a medical modality. Good news for us is that the medical world is beginning to see the importance of health versus disease management and are beginning to couple it like we are as nurse practitioners at this time. So with the medical model, it's about illness. It's about emphasizing the treatment of the disease rather than looking at, again, congestive heart failure and doing things to work with that from a health focused perspective. I can share with you that while this is still occurring, there are numerous providers that have come onto the bandwagon and are not just, handing over the Lasix and the metoprolol, but are telling the patients they need to lose the weight, they need to be dieting. The piece that's missing is helping the patient do it. And helping the patient do it is not a specialist role. That is a primary care PCP role. So while it's told to the patient in a specialty setting to do things, it literally lands on the PCP to guide, help, mentor, coach that patient into those items and help them achieve what the specialist is asking them to do. The WHO definition, I think it's pretty much self-explanatory, and it is a fundamental right of individuals. The problem is the social determinants and that health is something that has to be paid for here in the United States. And if you're unable to afford it, you may not get the care that others get that can pay for, which is totally wrong, but it is how it is set up here in the United States. If you are in Canada or New Zealand or Australia or Japan, or the Netherlands, England, if you are there, it is part of your right as a citizen. And when you pay your, what we call taxes here, it goes into that fund and you automatically have access to healthcare, and it's socialized medicine. There are weights and there are some negative drawbacks to it. And I'm not going to say that one system is better than another. In Japan, for instance, with their socialized medicine, people are held responsible for their health. And one of the things that happens is that they have to go to designated health centers for documentation of their health status that is reported via, if they had like a social security number like we have here, and it's linked into their household, and they measure weight and waist circumference. If the individual exceeds the acceptable parameters that are put forth at a national level, that person is automatically entered into a intervention funded by their country, and they don't have a choice. They have to go into this program and they have to work with the specialist to get their weight down and to go ahead and come into the parameters. They're typically given anywhere between 6 months to a year to make this achievement. And if they don't meet it, they wind up being taxed. Or I'm using taxation because that's what we do in the United States, and it makes more sense to say that. But they get charged and they have to start paying more than other people because their health is no longer healthy. They now are at risk for disease processes, which will put a strain on the healthcare system and require them to use more resources. So therefore, because they are using more resources, because they are unhealthy per standards, they will pay more. And that's how Japan happens to do it. Pretty interesting. It's something that was tossed around here in the United States a couple of years ago, never went anywhere, but it's still sitting out there just as an FYI. Knowledge is huge. Knowledge is power, and knowledge allows a person to be in control of what they perceive are uncontrollable situations. And this is really huge. And here's where you as the nurse practitioner come into play with your education. So there's a lot of different concepts associated with health. And on the right-hand side of the screen, these are the influencing agents that interplay in on health. And as you look at that list, you can identify, I get that part. I understand why this one would. Environmental, no brainer here. Like if you live out in the sticks of Pueblo, you don't have good access to healthcare. If you live here in the greater Denver area, you have access to healthcare, but it is so overrun with patients that it could take you 6 months to see a specialist. So we do have factors that interplay in. We're going to go over these a little bit more. So looking at organizational, we have all the elements on the left-hand side. Institutions have in place policies. These policies can be barriers. They also have regulations. We have an electronic health record, which actually is helping people. And technology is a huge component of organizations, but it can become a barrier to patients if they don't know how to use technology or they can't afford to own a technological piece, such as a smartphone or a computer or a tablet, to be able to access what an organization is asking them to do. Environmental is where we live and the ability to get items that are influencing our health, like fresh fruits and vegetables. Is there the access to a healthcare system? Is it safe to walk the streets? Is it overwhelmingly hot and therefore in a dehydrating atmosphere, or is it imperiously cold and individuals are not able to appropriately engage in activities because of the dangers that can come from it? So environment has a lot of factors that interplay in. Economic, I believe that you have a pretty good understanding of that. This goes all the way back into your baccalaureate education. But looking at it from a nurse practitioner perspective, it's if I'm going to give an intervention to my patient nutrition wise, are they going to be able to buy grass-fed beef, free range chickens, or free range eggs? Are they going to be able to afford organic vegetables? Do I need to inform them how to wash their vegetables to reduce the chemicals that could potentially be on them that can build up in their bodies and cause harm? Are they able to afford apps? Are they able to afford resources that I may recommend to them? Can they afford a gym membership? All of this I have to take into account when I begin putting together interventions for my patients. The sociocultural one, this one has significant implications from multiple perspectives. And of course, the cultural perspective and that culture that the individual was raised in. Are there barriers of things that I want to do medicinally for them that culturally that is not approved to be done for them? For instance, with the Jehovah's Witness, they don't take blood and they won't take a blood transfusion. And if that's what's needed and they refuse, what other type of intervention can I work with them? Drug prescribing and understanding that those prescriptions may have to be changed into a different language so that an individual will understand them. Genetics is a huge component. We're going to talk about that a little bit more today. And the other ones going down, I believe that you can gain a pretty good understanding of why those are influencing factors. I don't remember who said it, but one of you had talked about, oh my God, Allison, I think it was you who were with Yoko and the female inmate who had been released from prison, I believe, and she didn't know what a carbohydrate was. Perfect example of the importance of us understanding all the way down to that nano piece, that itty bitty little piece, to be able to get across a concept that's so complex and make it simple. Then we have behavior. And with this behavior, we've got our cognition, which is our thinking. We've got my motivation. And right underneath motivation, I have time. And I will share with you that when it comes to having people be self-responsible for doing things and for making change, the number one reason they tell you they can't do it, I don't have time. I'm sorry, I just don't have time. I don't have time to prep my meals. I don't have time to exercise. I am work, 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 working. Well, you know what? I think it's amazing that you're work, 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 working. So if you can't find time to try to work with your health, let's take the next 30 minutes of this office visit and let's plan your funeral. Let's decide on the coffin type, the lining of your coffin. Do you want to be cremated? Let's pick your mortuary. Let's pick out flowers because you are going to have some kind of an event occur, XYZ. When patients tell me this, and I've tried and I've tried and I've tried to get them to change and they don't change, then I am wasting their time and I am wasting their money. And I have said what I just said in my office with patients who do not want to do what they need to do and are trying to put it all on my shoulders with drugs. Drugs do not fix things. Drugs help the symptoms by altering the body's natural chemistries. And they always come with some form of risk, side effect. Normally, when I tell this to a patient, it takes them by surprise and they'll go, well, what are you talking about? And I will very kindly say to them, I have done everything I know how to do, but you're not following through. And I can't keep doing it without you helping. So we might as well do something constructive and we can look at planning your funeral, which will come sometime in the future. That usually gets their attention. It's worked every time that I've said it. It's not what I want to do, but they will start taking the medication. They will start looking at their diets. They will start trying to lose weight because I've reached the ability of what I have as a provider to help them. Physical activity is huge. People don't want to engage in physical activity. Part of it is social cueing that's happened to them. If you think about it, physical activity stops when you exit high school. And what happens when you exit high school is the expectation that you work. And what's the other expectation? You work more. And what's the next expectation? That you work even harder. Physical activity has dropped off. So we've lost nutrition because we're working so hard. And we've lost physical activity because we're working so hard. We do not in this society have a work-life balance. There are some institutions, for instance, Google and the corporation Epic, who does the EHR, and there's one more. Who is it? It's not Hewlett Packard, it's Microsoft, who within their corporate structure, the health of the employee is paramount and it actually takes precedence. And individuals are compensated for how well they are able to maintain their health and what they're doing to keep themselves healthy. They're rewarded with both in salary and in time off. I would like to have that same kind of a thing. So we, as nurse practitioners, we have to work with a shifting paradigm that people don't value exercise activity, and how we can shift that paradigm is how I'll be educating you in this course about the physiology of exercise that you're able to use as a motivational tool for your patients. Again, work, work, work is what we do in our society, and there's a lot of stressors. And with COVID, these are even higher right now. People don't engage in stress management. Again, why don't you? I don't have the time. Why don't you have the time? Well, because I just don't. I just don't is not a reason. It's an avoidance. So you sometimes have to drill and it's uncomfortable to drill, but in order to get down to the brass tacks of it all, you do have to, they have to be able to see it at a conscious level. We'll be working with stress management a little bit later on in the course as well. And then we already began alluding to the diet and eating. There's a lot of relationship between health promotion, and health illness. Our role, as I said previously, it is really expanding as nurse practitioners. We actually do an amazing job in the health promotion realm and the preventative realm. And providers don't really want to work with this because of the reimbursement, and the reimbursement is different. Our reimbursement system has been that a provider got paid when the patient got sick and came into the office. The sicker the patient, the greater are the bills, the more the provider makes. Medicare is one of the largest controlling and change factors in the United States in relationship to healthcare. And Medicare is shifting its payment structure. And now they're wanting providers to demonstrate how they are working to keep patients healthy and are beginning to reimburse for the health of the patient, as well as when the patient is ill and needs to be seen. If you do not meet certain parameters or markers that are indicative of health promotion, the institution where you work gets penalized and money gets taken away. And nobody wants any money taken away, especially from the government reimbursement. So they put in place lots of checks and balances to make sure that the things that Medicare says should be done are done, especially for those over the age of 50. So that's where a lot of your screenings are coming from, like colonoscopies, mammograms, DEXAs, the DEXAs for osteoporosis, the low level screening CTs for smokers and lung cancer. All that's coming out of Medicare, and all of it is preventative. So prevention, we have 3 different levels of prevention. Primary means that this person does not have any disease at all, and we're trying to avoid it. So think of your COVID immunization as a primary prevention. Secondary prevention is about, we have a disease process. I have elevated blood sugar, and you are trying to keep me from it progressing into full-blown diabetes. Secondary prevention. Tertiary prevention means that I have diabetes and I'm on medications and I may be overweight, and you are trying to work with me to optimize my health and continue to try to get my body back into a healthier state and to hopefully help me reduce my weight, increase my physical activity. I won't have to take any more medications. I will always be on guard that I could redevelop the disease process, but trying to actually get me to reverse it. And we can reverse chronic disease if we can get to that chronic disease before it reaches the point of no return. Let's take congestive heart failure and left ventricular dysfunction. Can we get to that person and try to reverse this heart failure? Yes, we can. But if we get to them too late, the damage is already done to the left ventricle and we can't reverse that damage, but we can sure optimize their health. So what does health promotion actually require? Well, we are an advocate with our patients. So we're their advocate. The patient must be involved in this. So they are an active participant. We're an active participant to a point, but most of that lies on the patient. The social support, think of family, think of ourselves, and then everybody is different. And not everybody is going to be out of up to date. Everybody should do this patient education guideline section. Because people can't do everything that's in there. So we really have to understand our patients, know who they are as a person. And once we do that, then we're able to structure plans for them. So understanding what things empower that patient, what things excite them. We are always in a collaboration with them, and the patient has personal ownership of their health and the state of their health at the time that they're seeing them. Only they and they alone can own that. We own assuring that the interventions that we put in place are ones that the individual is able to do and that they will meet the patient's needs. Skill. This is both on my end and on the patient's end. The skill to translate into a language that the patient is able to understand, skill of the patient to be able to navigate and engage in what we're asking them to do. Time, I think, it needs to be like bolded and 6 times the size of this. As I said, everybody tells us, I don't have time. We here in the United States are in such a push to meet the needs of our employers that we sacrifice ourselves. And we as nurses, we sacrifice more than any other profession out there. And our sacrifice is costing us our health. So with time, as a nurse practitioner, you understand that time is precious. But if an individual doesn't make time for self-responsibility and time to engage in change, then the interventions that you're putting in place and the elements of change that the person needs to do to get their body's homeostasis, metabolic dysfunctions back in check are not going to happen. And no matter how good your plan, this patient is probably going to have struggles and may not be successful at what you're putting together. And being honest with the patient related to time and explaining how maybe you got over a barrier of time and was able to do something speaks volumes versus saying to them, well, you're going to have to figure out a way to make time. Just saying that is placation, and that does not go over well with patients. So I would not say those words. And then again, educating that patient. So what needs to come first? Do we need to educate? Do we need to prevent? Do we work on promotion first? Or are all of these literally moving tabs that remind me of the floating stairs in Harry Potter? And that they're constantly shifting and moving depending upon what the patient's needs are. And that description is what really happens. The patient shifts and moves, and we as providers shift and move along with them to meet them at where they're at for what their needs are in that moment when they're in our office. So the World Health Organization has these 5 elements or actions of how they say we need to be working across the continent and around the world to help people. And if you look at these, a lot of what we are doing in this course is teaching you how to be creative, how to strengthen actions, how to develop your personal skills to then translate to the patient, and how to reorient into a health-based versus a disease-based platform to be able to combine the two together. So when we look at the dimensions of health and wellness, we've got a plus and minus. And in the middle is where we actually have our balance. So with emotional and mental, we're either happy or we're depressed. Intellectual, we're informed or we're ignorant. Physical, we're either fit or unfit. Social, we're involved or we're lonely. Spiritual, fulfilled or unfulfilled. And total outlook is positive or negative. And these can shift back and forth from a positive to a negative. And you can have some positives and you can have some negatives. We're really looking to get that balance in the middle. And that takes time, dedication, support, mentoring, and guidance by someone who cares for that individual. And an individual, once they believe that what you're trying to do is to really help them, they want to have you be happy with them. So they're going to try. I will tell you that some of my hardest patients try really, really hard and they achieve great success with multiple physiological changes that are for the better. And then they slip off the wagon and they revert back into bad behaviors. It takes at least anywhere between 6 and 12 weeks for a change not to feel so much like a change, but this is just the way I do it. And it takes every 5 weeks for them to be tagged with a support by an outside source to help them remember the importance of what they're doing. So just a little FYI on, they really need strong engagement by the healthcare provider to keep them motivated to continue forward. There's a lot out there in the news talking about, should health promotion and prevention actually be a specialty like cardiology or neurology? And should we take this away from primary care and stick it in a specialty? And this is very controversial, but these are the conversations that are occurring out there. And why are they occurring? They're occurring because PCPs are overrun and overworked because there is a significant shortage of PCPs in the United States. Hence, us as nurse practitioners coming in and working in that realm to help offset that shortage. We're in a very unique position as nurse practitioners because our education when we first became nurses in the BSN program was patient-centered. We didn't have to be told about being patient-centered. It's who we are, it's what we do, it's how we think. That is our leg up in working in health promotion and prevention. Looking back over how you have been educated in the past and what it looks like now, historically, you have not received as nurse practitioners appropriate education for you to be able to clearly speak to a patient with intelligence about how nutrition, specific nutrition, can help them healthy. You may not know anything about physiology related to exercise and brown fat, white fat, how it works on mitochondria, how it stimulates ATP. You may not have learned any of that, but that's what we need to learn in order for us to understand how do we use these as interventions. So this course is teaching you how to understand these elements from a physiological perspective to apply them as intervention. Just like you learned in pharmacology, how a beta blocker works and how it blocks those beta receptors, and then its physiological response that's occurring in the body. You're going to learn that in this class related to exercise, nutrition, and how do these correlate into weight. It's pretty fun. This is a cool thing I actually use in practice. You can download it from the web, but it's a health report card. And my patients are coming in for their yearly physicals. I will have this given to them. And what they're going to do is they are going to check mark elements of what they know about themselves. So the MA will go ahead and get their weight, weigh them in, do their height, and they will check for them where their body mass index is. We do a finger stick and get a fasting sugar right away. We also have the ability to do a, what is it called? I can't think of what it is. I can't think of what I want to say, but it's a quick assessment that we're able to do to get a hemoglobin hematocrit and potassium, sodium, and get just a total lipid so that we're able to get some kind of an understanding where that patient's sitting before I get the complete panels. And then we also look at blood pressure. So as soon as they come in and meet the MA, we're able to give them a scorecard on where they're at. And then on the right-hand side, they're able to look at how they're doing with their healthy diet, their physical activity. If they're a non-smoker, they get to cross that whole section off. If they don't use alcohol, they get to cross it all off. But if they do engage in those activities, they're able to look at it and see where they're at. And then they visually can see where changes need to occur to help them get healthy. This is then given to me, and then we use it as a template to begin a conversation about how to optimize their health from some of the major psychosocial elements that affect health. Going back to the iceberg. So health, we're going to flip it. Health sits at the top. Now on the other iceberg, it was disease at the top and health promotion on the bottom. When we look at health, health is on the top. It's a very small portion of all the elements that underlie the ability of an individual to be healthy. And that makes sense. If health is just the tip of the iceberg and all the elements that go into what makes a person healthy are bigger than what we see, and it is, makes complete sense why it would be an iceberg. And you can use this iceberg and you can draw an iceberg on a paper towel for a patient and and make a little hill on the top and put a line for the water and then write them on the bottom of the iceberg, the things that are affecting their health. They can visually see it. And when you do it that way, it has such huge power. I do drawings all the time in clinic, and I make things simple for patients to understand. And the iceberg is a real simple way for a patient to understand that there are so many things that affect their health and how you can work with them. So now we're going to move into genetics, which is one of the funnest parts of this course today, and social determinants. So epigenetics, and there are videos that you guys are watching this week, and these videos are incredible. They are amazing, and they really help you begin looking at things from a completely different lens than you may have been looking at health before. But our parents actually passed on to us our genetic information that is going to cause us to have diseases, be heavy, be thin. And it all happened before we were even conceived. Now, I have the ability as an individual to control what happens with the epigenetic information passed on to me and the influences of my diet, my exercise, and my stress will cause me to look like the boy here. If I control it and do it right, I will look like this. If I can't, I will look like boy number 5 at the end, extremely overweight and obese. And I can tell you that I actually watched this happen with one of my own children. She was skinny, mini, 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 me. She weighed 110 pounds, 5'8", got out of college, stopped eating properly, stopped exercising, and she blossomed up to a 180-pound woman. She hated herself. What happened to her? I gave her the right epigenetics, but she didn't influence those genetics appropriately in her adulthood through her nutrition, her sedentary lifestyle, and managing her stress. I'm happy to say that she's addressing it and she's dropped herself back down, numerous pounds down. She will never be 110 pounds again, but she can get to a healthy weight, which I believe she's chosen 150, which is perfect for her height. But it can be devastating for an individual. And right now, I don't know if you guys heard the news, but recently it talked about our older adolescents that are between the ages of 10 and 13 being the heaviest in recorded history of health in the United States, and that more of this population are presenting with hyperlipidemia, hypertension, and type 2 diabetes. And care is having to start for them all because of nutrition, lack of exercise, and stress on these individuals. And it's not helping with COVID. So it's pretty interesting that we can't control what happens to our bodies genetically by the influences of exercise and nutrition. And we're going to talk more about it. So we look at that ecological component. The determinants are our biological, makes sense. Social, if I start, inebriating with my friends after class and having a couple of glasses of wine or a hard liquor, and I experiment a little bit and with some marijuana, and I try a couple of magic mushrooms and things, I'm already beginning to affect my health. Culturally, we have culture pieces that we may not understand as providers because we don't know that culture. If we don't know it, we ask. if you are going to recommend something and you know that this person potentially has a cultural entity that could interplay into their ability to carry it out, ask them if it's something that they're going to be able to do. They're very open and they will tell you that they can't and they'll explain why. Then you look for adapted things to do. An environment, I think, is a pretty much given. The genes that we are given and on our environment, all of these components of our environment are linked together and cannot be separated away. And each has a like a give and take relationship to where our body's health is.
Sounds-
Stress is extreme. Question?
Yes, sorry.
Yep, go
I
ahead.
just wanted to ask a question about the culture aspect on the last slide.
Mhm.
Do you have a suggestion? Because when we were talking about our clinicals, the same boy I was talking about, he kept referring to the family. The family doesn't want me to, the family won't let me. It was just
Okay.
the family. So how do you address without being offensive to ask what their culture may or may not be?
You know what? You won't be offensive if you say to him something like this. I am hearing exactly what you're saying. Help me understand how your family has difficulty working with this. I am respecting his family. I'm trying to understand the barrier within the family. And by understanding that barrier, am I able to come up with an alternative through my understanding that they shared with me to help this person be able to do an intervention I want them to do?
Okay.
And I like the word share with me. I use that quite a bit. And it's amazing because when I asked, I will say to that patient, share with me how this is happening. I'm trying to understand and I'm not understanding and I'm confused. Um, so if I'm saying that to you, so I'll say things two different ways, okay? Share with me what's happening in your family that's keeping you from doing this. Tell me what's happening in your family that's not allowing you to do this. Which one sounds gentler and more kind and respectful? The share or the tell?
The share.
Right. Doesn't it sound like a parent saying, tell me what you did?
Mhm.
And I'm not their parent, but if I ask them to share, it's I'm inviting them to reflect in their way. There's no judgment. Tell, that word tell it's a very harsh word, and there is a connotation of a little bit of judgment that's embedded in it. So I don't ever use the word tell. I use that word share quite a bit. And my patients will even tell me things I really don't want to hear about. But I'm respectful of that. And I had a patient last week say to me, she we were getting ready to end our encounter. And she said to me, I have one more thing. And the whole time we were there, we were not talking about this one thing. And as she said those words, she began to shake and silent tears began falling across her cheeks. And she said to me, I really do trust you. And what I'm going to say is so hard for me to say. So please just hear me out. In other words, she's telling me, shut my mouth and don't talk. And I did. And what I heard just tore my heart apart. And I went over to her and I gave her a big hug and told her that we would figure out a plan and that I would be there to help her. I was going to have her come back to the clinic during this time frame more frequently till we got to a point where she felt comfortable and safe. And then I would make the follow-ups a little bit more time distance. And that was exactly what she needed. But what she needed most of all was to feel comfortable in my presence, that I wasn't going to be judgmental of what she was going to say to me, and that I would please help her. It was really hard. It was really hard. And I'll share with you that there was a lot of components that were occurring in that conversation that took place in less than 5 minutes. It brings tears to my eyes. I'm sorry. But she's questioning her sexuality. And she's married to a gentleman who she loves. And she has 3 amazing kids. Can you understand the complexity and the torment that is running through her mind? And she didn't have to trust me. And she didn't have to say anything to me. And she could have continued in that tormented mental state and not shared anything and walked out that door. But she didn't. And it all stemmed from how I interacted, how I was working through what we had been seen for that day. And I wasn't going to let her down. And she knew that. That is a gift. Patients do not trust us when they first meet us. We have to earn that trust. It is stressful, as this image on the screen. It is stressful to go into a new provider because you don't know them and they don't know you. You don't know if they're going to judge you. You don't know if they're going to judge you ethnically, culturally, genderly. You have no idea. Are they going to judge you because you're a nurse practitioner and they're a physician? We don't ever know, but we have fear. And patients have that same fear. And how we help to put them at ease by letting them know that part of our main role is to hear them. We can put them at ease very quickly. Using those verifying, validating statements that you learned about in motivational interviewing are humongous. And they go a big, big way in health promotion and prevention and primary care. That was a really good question, Nala. Did I answer it for you?
You did. Thank you so much. Sorry, I didn't mean to make you emotional.
Oh, it's okay. It just brought to my mind. I care about my patients so much. Okay, not everybody I care about, but most of them I really do. Sorry, I'm just honest. But most of them I really do. And I have a really eclectic group of patients. Some of them just touch your heart and it hurts. And your hands are tied and there's only so much you can do. And it's on them. But sometimes it's just us letting them know that we care, that this is a human that cares, especially when they're struggling.
Right.
And just knowing, and it is okay to touch your patients, by the way, and it's okay to hug them if they want to be hugged. And she did. And I asked her permission, is it okay if I give you a hug? And she goes, I would so appreciate that. Human touch is something that is inbred in us as Homo sapiens. And without it, we have emotional struggles that we deal with, just as an FYI. It's just part of who we are as an animal. So moving back into the stress, I'm going to see this patient tomorrow, by the way. So my brain's already split in two on this one. On the stress diathesis model, stress is a nasty thing that happens inside our bodies. It produces significant amounts of inflammation that affect our bodies at multiple levels. And it's all chemical. And your body does a really great job of trying to manage those stress chemicals. So think of the free radicals, think of your cortisols, um, think of the tumor necrosis factors and the interleukins. They all get stimulated, and our body usually takes good care to basically bring them under control. But there are a lot of times, if we don't correct the underlying stressors, it literally undermines our body and it begins that inflammatory environment. That inflammatory environment is one of the main triggers of genetic disease processes. So I'm under a lot of stress. I'm being told, take it down. I say, yeah, I'll do it. I don't do it. And day number 34, I have enough interleukin, enough free radicals that it begins damaging my genetic linkages. And all of a sudden, one of those linkages is a trigger on my cellular tissue of my breast. And now starts the cycle of breast cancer. And I don't even know it's happening. I don't, but it's begun. And the changes occur and the cycle cannot be stopped. Even if I change and get everything under control, once those cells begin that change associated with cancer, you can't stop it. We have to kill the cells and then regroup the body and get the body back into a homeostatic place to allow that body to heal and not, again, trigger those cells. A lot of the autoimmune diseases that individuals have, so the ulcerative colitis, lupus, Sogn's disorder, rheumatoid arthritis, autoimmune immunology components, a lot of our heart disease, all of this is related to inflammatory markers. And we're going to talk a lot more about that. So this is a really complex slide, but let's keep it simple. This cortical releasing hormone, the CRH, comes out of our hypothalamus and it is stimulated when I'm under a lot of stress. And this hormone then sets off a cascade of other chemicals in my body that are related to stress and inflammation. Bottom line, when my corticotropin releasing hormone gets let loose out of my hypothalamus, it sets off a cascade for other hormones in the body and chemical to be released that trigger other inflammatory processes. And now it starts. Bottom line. This is a chemically mediated process. I just don't go to bed at night going, you know what, tonight I would like some more cortical releasing hormone to come out. Could I go ahead and make that happen? Could I possibly have, maybe a mil or so would be okay with me. It happens by the chemical burden of those chemicals associated with stress. Pretty hot, huh? So when it comes to genetics and the determinants of health, gene regulation and mutations, we turn them off or we turn them on. And this turn on, turn off literally is mediated through chemical processes associated with diet, because we metabolize the foods and chemicals come out of those foods. Exercise produces chemicals that are your turn off mutations. They help to not let something bad happen in your body. But if you don't exercise, those chemicals that we need to control inflammation that come from exercise don't happen. So the inflammation that's occurring chemically because of what we're doing with our lifestyle is actually mediating, and it's a turn on of that gene. Most of the mutations that occur that we never see, nothing ever happens to them because we can get a handle on them and reverse the inflammatory process. But if we don't, that mutation that in the original state just produced some mild inflammation then turns into a significant disease process. And remember, it's all chemically driven. Everything in this body that happens to us that is disease related is chemically driven. The genetic disorders that we have at birth happen because of genetic mutations that occurred in that person in utero. So they happened in utero for some reason. Again, it's chemicals. Something chemically happened, and we don't know what that always is. So epigenetics, which we're going to be talking a lot about in this course, epigenetics refers to inheritance that is not explained by changes in the DNA. So epigenetics means that I didn't get this because my dad had it. Okay, that's DNA. I got this because I porked out on brownies, hot fudge, whipped cream, and I love, love, love cookies. Okay, let's see. Sugar and fat. That's what I ate. Sugar, fat, processed wheat that's highly metabolized into a carb that is a sugar. I just went ahead and beefed up every inflammatory marker in my body. Epigenetics, it's about the things that we do that can affect our genes that we were given. As it says in the next sentence, highly influenced by internal and external cellular environment. Internal environment, it's everything that I put inside this body that chemically is released out into my blood system. Externally, we have to think of, I want you guys to think of the smoke that's been coming into Colorado. It's external. I'm breathing it in. It's producing inflammation in my nose, in my eyes, in my throat, and in my lungs. External environment. And mechanism. These are two big ones. So these influences that are occurring that are my lifestyles. It's about where I live and what I do for myself. It's the methylation and it's the histone modification. What I do, what I eat, how I manage stress, I think stress of inflammation, and how I exercise, control the inflammation or don't, will then affect how your body does methylation and histone. So methylation, this is complicated, but to make it simple, methylation is basically my cell making itself over and over and over again so that it looks just like my skin. It looks just like every heart cell. It looks like just like every colon cell that I have. But if DNA methylation occurs, this means that there is a genetic change that occurs to affect the gene prior to the gene going through its cellular division, dividing itself and making a new cell. And the DNA becomes modified. And instead of me getting the normal cell, let's call this a colon cell, it turns into a colonic cancer cell. And this starts dividing and replicating. Other cells will still replicate normal, but more cells will replicate that are cancerous. And this cell change occurs from the chemical influences that occur within our body. So as the statement says, it's a biochemical alteration that affects the DNA with methylation. Methylation helps to keep that DNA nice and tightly wrapped. And it begins to unwrap, and that methyl group is what does this. And I'm going to show you a picture of that in just a minute. I could spend an entire semester talking to you about genetics and how it all works. And I have to like trap it down into something manageable and easy for you to understand. So DNA methylation, the methyl is a group on our DNA. We keep it all nice and tightly packed. We get a normal cell. If this process becomes affected by chemicals that we bring into our body, It can affect this process, this DNA process of methylation. It alters the process, it alters the cell, and the cell now becomes vulnerable to changes that could be indicative of disease and cancer. Does that make sense? If it doesn't, somebody speak up.
So sorry, just for clarification. So what you're saying, Kim, is that like the choices that we make, like things that are not genetics, eating high fat, high sugar, those types of things can alter the methylation. Sorry if I say this wrong. Methylation
Yes.
of our DNA.
Correct.
Wow. Okay, that's crazy.
I know. Now, our body normally can control it. But like I just said, I just chowed down on quarts and quarts. And I mean, I eat a quart of ice cream every week and 2 packages of cookies, and I add in whipped cream. Remember, everything we take into our body, even drugs and vitamins and supplements, they all get broken down into a chemical component, chemicals. And then it goes out of our bowel and into our bloodstream. And it begins affecting everything. It truly is, oh my God, if I do a better job with my diet, I can stop disease processes. The answer is yes. And here's the best thing, you guys, we can reverse disease, exercise, stress management, which is inflammation, and diet. We can. Okay, so the next one is a harder one. This is the histone. And the histone is another part of the makeup of our DNA. And it's part of the proteins of our DNA. And so we have that methylation. I'm going to show you another picture in just a second. But if you look down here at the bottom, these little blue balls, these are the histones. Okay. So the histones are sitting over here and they're making up the protein of our DNA. And they couple themselves in very specific relationships. So think of it that way, coupling into special relationships. Okay. And there is this protein here, this little chain thingy that goes around them and keeps them in that coupled relationship. That coupled relationship, and the coupling is called the chromatic structure, which is what this is down here. This structure, then if we keep it the way God intended it, we get normalcy. But if we mess with the package, in other words, I remove a blue ball or I loosen up the binding component, like a methylene chain, I loosen it up. Now this is not what God intended. And I have now produced a new genetic chromosome relationship that's not normal. And if this replicates itself with this abnormality then begins damaging other normal chromosomal packages. They don't repair themselves properly. Now we get disease and cancer. Let's see a better picture. So this is a better picture of it. So the DNA methylation, so this is your methyl here, these little blue guys. You guys, no barking. This is the methylation, and in here we've got our chromosome representation. All right. So if we have gene expression regulation, if we up-regulate it, we silence it. If we down-regulate it, we get expression. It's like, okay, that makes a lot of sense. Not really, but okay. So if you think about it, our genetic expression, if I wanted to say unchanged and just leave it the way it is, and it's normal, and I'm okay, then silencing the expression is okay at this time. But if I undermine the ability of my gene to properly remanufacture itself the way it's intended, alterations can occur. Okay. So things that can affect DNA methylation foods are folate, green tea, and selenium. Physical activity, it actually helps with DNA expression and supports it and keeps it as a healthy expression. Intrauterine life is affected by maternal diet, drugs, smoking, and stress because stress produces bad chemicals. Alcohol intake is going to affect the expression, and pollutants. All of these begin to affect how this gene is going to replicate itself. Aging overall, it does. Stress is huge. Remember, stress is chemicals. Chemicals are bad. It's kind of like the Finding Dory with the shark saying, fish are our friends. We don't eat our friends. Well, stress conditions produce chemicals. Chemicals are not our friends. They produce changes in our DNA, leading to disease and leading to cancer. That's the bottom line. And unfortunately, I hate to tell you this, you guys, but those of us that have worked night shift, we basically, put a nail in our coffin because it actually caused circadian rhythm changes that are associated with free radicals, cortisol, and leukotriene, or not leukotrienes, tumor necrosis factor elevations in us. And we set off triggers affecting our DNA. And that started within 3 to 6 months of us starting shift work. I worked as a night nurse in the ER for 26 years on the night shift. I did a boatload of damage to my DNA. And as I'm turning into my 60s, I am seeing how my DNA has been harmed and working to reverse it if I possibly can. So over here on this side, we've got different types of foods again that are helpful. And this is the histones. Covalent modifications to histones can occur through these. Relaxed compact chromatone structure associated with differential transcription activity. What it's basically saying is that the polyphenols from vegetables are actually a good thing, and they help support that histone redevelopment and packaging component and help to keep it in a healthy format. And we actually want that to happen. Okay. Cigarette smoking, the nicotine out of the cigarette smoke, as well as the charcoal component that comes from the burn of the ash, actually are carcinogenics and actually can absorb across the blood barriers into cells and begin unraveling and affecting that histone and methylation, leading to the development of genetic changes. So when we're looking at the epigenetics, we have our normal chromosome, epigenetics. These are the things up here that will affect my chromosome. The chromosome is part of my DNA. We have the chromation, which is the normal activity of the bonding of the histones and the methylation process. Coming down in, we're going to get to the micro level. So here's our micro level. So here's a little baby methyl group that's attached over here to the histone. This is what's going to get affected by this up here: the development, environmental drugs, aging, and diet. Okay. Okay. So we bring in abnormal chemicals from outside and put them inside our bodies at a certain amount. They begin affecting the methylation of the DNA. Coming over to the closer look. Okay. So we have our histone, which is our packaging around our DNA. All right. Remember that the histone is a protein, which the DNA can wind for compaction and gene regulation. If we damage this protein, we damage its ability to wind around the DNA and affect that DNA's ability to regulate itself which means that cells can go wild because they can't regulate themselves not to grow fast for cancers or begin adaptations associated with disease processes. So if we damage the DNA or we damage the histone by one of the epigenetic associations, this is what will happen. Whoop, I'm going to go back. Sorry, I went too far. These are cool pictures in just a second. Okay. So when you get in here, what happens is we start having genetic changes in the actual histone's ability to wind tightly around that gene. It doesn't do it. And it begins bringing in chemical components and bringing them into that DNA of whatever cell it's a DNA of. And they make these little tails. And these little tails begin affecting the tightness of the histone and the actual activity of the normal DNA cell. Come up to the top. So what does this mean when the methylation process of the DNA? So think of methylation as methylation is the reproduction of my gene exactly as it was made when I was conceived. Think of methylation as that, and think of histone as the protein that wraps around the genes that keeps them in the sequence that they were intended for their function. So if we disrupt either one of those, what do we get? We get cancer. We get an autoimmune system that doesn't function right. We can develop mental health disorders and we get diabetes. Why isn't heart disease here? Why? Because heart disease is an entity of inflammation. Inflammation occurs in relationship to diabetes. Most individuals who have heart disease typically have some component of glucose elevation and or inflammatory markers that are elevated secondary to stressors. And stress is associated with the inability or maladaptive coping of individuals, which is considered a mental health disorder. Let's take a look at this at a more granular level, okay? So epigenetics means, so what this I'm showing you here, this is actually a glioblastoma. And how does an individual potentially get a glioblastoma? Well, a glioblastoma occurs secondary to mutation that occurs in cerebral tissue. Now, where does this mutation occur at? So up here on the top of these headers, these dark line headers, these are all genetic ligands, if you will, and this is where this one occurs at. So this one is a hypermethylation that occurs in young adults. It occurs here. In adolescence, it occurs here. And this one's a hypo. In children, it occurs here with this mutation at this genetic reference. The mesenchymal expression can happen anywhere. And the PDGFRA amplification occurs at all levels. Over here to the right-hand side, chromosome, beginning expression of methylation, histone mutation occurring here. Remember, the histone is the wrap. Here is the change. And up with the young adults and the adolescents, it's actually occurring in the methylation that's occurring within the chromosome wrap inside the cell. Mutation, 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 mutation. All mutations. Let's get a little deeper. This slide is extremely telling. So these are all of the different types of epigenetic problems that can occur in an individual and how they occur. So the CCR5, this one is a delta 32 deletion, and the environmental exposure is HIV. The mFER is this variation. It's associated with folic acid intake, and it can cause colorectal cancer. Now, an individual has to have this mutational variant to acquire this. How about NAT2? This one is a heterocyclic amines in cooked meat. So I want you to think of processed meat with nitrates. Colorectal cancer with rapid accelerators. We don't know if a person's a rapid accelerator, but have you noticed how a lot of our processed meats are going nitrate free? Why? Because I'm in my 60s, and from the time I was a toddler to now, well, probably about 5-10 years ago, almost every one of the lunch meats I ever made had nitrates in it. Am I a rapid accelerator? I don't know. I don't have colon cancer. But here's another, for instance, I have a nephew who at the age of 28 developed colon cancer. He's 28. Do 28-year-olds get colon cancer? No, they typically don't. And he had a hard time convincing his primary care provider to do further treatment. They kept saying that he was straining with weightlifting. You're not going to poop blood with weightlifting, just as an FYI. It doesn't happen unless you pop a hemorrhoid and then it stops. But he probably is a rapid accelerator. I've never asked him, but he probably is. And he did eat a lot of protein products and ate a lot of lunch meat. So that could be it. So as you're looking down here, you can look at what's my exposure. And if I have this exposure and I have the genetic predisposition, what will happen to me? Go backwards.
Hey,
What's
I
gonna
just
happen?
interrupt really quickly? I just have
Yeah.
a quick question.
Yeah.
So what I'm kind of understanding you saying is we all have these gene expressions, but if we have the variant already plus the environmental exposure is kind of when you
Think of it as
display
the
the disease.
think of it as the flame
Mhm.
to a firecracker.
Okay.
And we don't know we have them. We don't know we have them. I know. It's like, oh my gosh, well, shouldn't we be doing more personalized medicine to find out before we start doing things to people so we can probably care for them? That's the conversation we're going to be having in just a minute. That's a good question. Thank you for asking that.
Thanks for
All right, you
clarifying.
guys, this is schizophrenia, and this is the environmental exposure that could potentially cause an individual to have schizophrenia. Look at the genetic relationship. Isn't that huge? So, but I want you to take a look at the prenatal. Look at prenatal and look at what happens with bereavement. What does bereavement cause in an individual? What does it produce?
Stress response.
Yes, Emily, you're right. It's stress. And what does stress produce in our body? Starts with a C. Just
Inflammation.
inflammation chemicals. It's the T necrosis factor. It's the cortisol. It's the free radicals. It's all these nasty enzymes. Okay, now we have it, you guys. In utero, if I have a death in my family and I am stressed, I now run the risk of my fetus having schizophrenia later in life because of those chemicals. And this gets even more technical. If this happens during the development of the brain and spinal cord, that probability goes up even higher because of those chemicals. Isn't this just fascinating? Ah, this is just crazy stuff. Okay, so we've got the genetics part, and we're getting the understanding about how the environment affects us. We're getting it. And that's the social determinants, how these determinants interplay in. And we can't make social determinants go away. But what we can do is we can understand them, and we can work with them and work within what our patients are able to do, even if it's something just simple, because the simplest things can have the greatest changes in our human body. Cultural perspectives, there's a lot of cultures where there are food products that are part of their daily diets that they eat. And some of these products are actually protective, but other products are actually ones that can potentiate some of these epigenetic changes that we can see happen. And we're not going to change a culture, I'll tell you that. But what we can do is we can educate. And they may say, thank you for the information, but this is what my family does. And as Nyla said, this is my family and I can't stop it. So if they can't stop it, at least we've educated. And then we go into our monitoring mode and making sure that we watch that person. Leninger's theory of culture is amazing because this theory helps us really gain a foundational footing in understanding how culture plays a role in health, how it influences individuals to make the choices that they make, and then guides us as providers in knowing where our best bang for our buck for intervention could be. And it may just be understanding and just providing that education for them and giving them resources for them to be able to take back into their family structures, their community structures. They may be able to change nothing, but you understanding that culture does influence and that we can be constrained in doing the right thing for our patient by these cultural barriers. This is a great theory, by the way. Leninger's is a hard theory, but it's really, really good. So demographics also can cause issues in relationship to individuals in their environment, especially if it's in a high stress, crime-ridden neighborhood. Their bodies are always under stress. Can you imagine what their free radicals are doing? And these influences in relationship to our ecological environments, it's different living up in the mountains at 10,000 feet versus living in South Beach, Florida, which is at sea level. The environmental factors related to atmospheric pressure, oxygen, CO2, methane gas at 10,000 feet is quite different than at sea level. And these elements also come into play. Here in the Denver area, it is not unusual to find people with elevated hemoglobin and hematocrits, maybe 1 point, maybe 0.5 above normal. It's normal for some people, especially people who just moved here. So there's this new thing that's coming out there and it's called precision health. And now I'll tell you, this is controversial and I'm just presenting it to you because you're going to hear about it. I'm not telling you this is what we should do or what we shouldn't do. My job is to educate you on what's happening out there in the world, and precision health is happening. What precision health is, it's that it's using genetic profiling to help with diagnosis and treatment. And it's having individuals go through genetic testing for pharmacogenetic mapping prior to any medications being given. It is typically administered early in an individual's life, probably in their 20s, so that we get an understanding of genetically what they are at risk for genetic change in their body and what genes could potentially be affected. By an individual knowing their genetic profile, we are able to put in place plans of care that are supportive to reduce genetic change. Does that make sense? This is a wave that's just starting out in the middle of the Pacific Ocean, and it hasn't even come to shore yet. But this is where we're looking at going probably by 2030. Every patient that we see in the clinic, prior to seeing them, they'll come in for blood testing. We'll get their genetic profiling, we'll get their pharmacogenetic map, and we see them for the first time to establish care and their preventative care visit is going to be on, you are at risk for developing these diseases. These are the drugs that we will need to avoid in you. Let's begin the plan to look at how can we keep these disease processes from occurring in you with diet, nutrition, exercise, and stress management. This book is about $190. I think it actually was $230 when I last looked on the web. This is an amazing book. It is about medical genetics and genomics. The chapters in it are amazing. They help me understand the why. Why does this body chemically begin to change when my size begin to change? And how does it genetically affect me? How does diagnostic molecular, the diagnostic genetics molecularly? This is looking at different drugs. Lysosomal storage. Oh my God, this is huge for, so why are some people like super skinny and some people like they can't even eat like half a carrot and they gain 10 pounds? An amazing chapter. Then it has the genetic evolution for chronic disease. This is awesome. Screening the heterozygomatic testing. This talks to you about who to test and why to test. Chapter 11 is my favorite in the entire world. It's the circadian rhythm. And if this gets disrupted, how it leads to disease. Think of the circadian rhythm as your repair and restore time for your body. And if you don't have time to repair and restore, you can't reverse the free radical damage or the inflammatory damage that is happening in your body. Baby, you might as well just write your ticket for heart disease because you're going to get it. An amazing chapter. I just mentioned this book because I find it to be phenomenal. I loved the reading in it. It made me view patients with a different lens of understanding that literally brought me right down to the ground and really got me focused in on, I can work with exercise, nutrition, and stress. I can stop all of this from happening. Available on Amazon. You can get it through Barnes and Noble as well. It is a pretty pricey book, but if this is something that you're really super interested in and you love this kind of stuff, highly encourage it. So there's a lot of consumer products that are out right now, and you're going to be working with consumer products with our patient Alex that we have in class. This happens to be from the Mayo Clinic, their Genie Guide, and you're able to go ahead and order genetic testing through the Mayo Clinic. They have a genetic testing bank, and you become part of their bank of genetics. So as they begin learning and understanding things that are genetically related, when you make the choice to utilize their product to learn about yourself genetically, you automatically are self-enrolling in the Mayo Clinic's epigenetic research. And they can reach out to you and let you know, hey, by the way, we found you to be a rapid metabolizer for the cytochrome P450 family of 2-DBTIA. We would like you to try and avoid these medications. This particular gene site will help identify if you're a carrier. So it does carrier screening. It does disease risk. So it looks at your genetics and looks to see what you potentially could be at risk for disease in this moment in time when you do the test. It can help you understand your medication response. Again, every single medication we take in our body, most of them, 95% of them, have to go through the liver for metabolism. I remember IV medications don't have to go through the liver for metabolism. They're already in their active format, but anything oral has to go mostly through the liver. Nitroglycerides, sublingual doesn't have to. So there's some of the sublingual things that don't really have to. But this is super cool, especially for people who are struggling with depression and they've been on one medication and then they've been on another one and it's not working. Well, maybe they're a slow metabolizer, or maybe they're a super fast metabolizer, and that's why they're having problems. And then it looks at health traits. So Mayo Clinic Genie Guide, you can actually look this up online, gain more information from it. It is not cheap. These are a little bit pricey. They have another thing that you can do, which is your lifestyle risk assessment. You have to be honest though, when you answer these questions. If you lie, it's going to give you your lies put back at you. So make sure you tell patients if they're going to use this, that they have to be honest and truthful. Otherwise the information is useless. The breast cancer screening tool, pretty cool if you've got a pretty strong history of breast cancer, but going to the carrier screening, I can get that same information and more. Pedigree, this is kind of like ancestry.com. Both of these are like that. For patients that I'm dealing with and they want to do genetic testing, their insurance companies won't cover it. They can bring up 199 or 299 and do one of these, and I can get pretty close to the same results. 23andMe is another one of the consumer-based products. 23andMe came under scrutiny by the FDA because 23andMe, when it first started off, it was giving out massive amounts of genetic information. Everything from you are at risk for these diseases, you already have in process genetic changes associated with these diseases. You should not take these medications because of X. And it went through and explained all of the liver enzymes. And they came under scrutiny by the FDA and they had to stop giving out that information to patients. So they cut back what they were giving to patients by pretty close to 50%. So you have your genetic health risks and you have your carrier status. These are two elements that they will help provide you information on. When you're talking about breast cancer, which is one of the main elements that these screenings that we just talked about, that we could do genetically through Mayo or 23andMe, Ancestry.com is not going to really provide you with a lot of information. Ancestry.com is really just looking at your genetics for specific mapping profiles that match cultural and ethical aspects of individuals, but you're not going to get a lot of risk information or potential medication things you should avoid. That's going to come from Mayo or it will come from 23andMe. There are other companies out there. I encourage you to go look and read about them. Your patients are asking about them. I actually refer patients to the Mayo Clinic one. I find it to be outstanding and it's not that expensive. Harvard also has one. Harvard, the Health Center has one too. I would encourage you to look at Harvard as well. But talking about breast cancer, we have a lot of different genes that can become altered. And we know about the BRCA1 and we know about the BRCA2. We understand that. And there's others though that can also be associated with different changes. So here's your big ones, your BRCA1 and BRCA2 for breast, your CDH and your CHEK for colon, the CDH1, this one is the lobular cancer. I actually have a sister-in-law who has this type of breast cancer. She was diagnosed when she was stage 4. She has now hit her 5-year remission mark. Again, looking at CHEK2, can be associated with breast cancer, colon cancer, and prostate cancer. A lot of times you'll have an individual that develops like ovarian cancer and they immediately go looking to see if this individual has breast cancer as well, because ovarian cancer can metastasize to brain, liver, and spleen. So they go looking for them. So this explains a little bit about how the BRCA mutations work. They're an allele that becomes affected, and that allele function declines with age. So in other words, it's more susceptible to damage and doesn't have as great of ability to repair itself. And because it doesn't have that ability to repair itself, it's more susceptible to those chemical influences that we bring in from the environment. And through that, we begin to have alterations in our DNA, which then start affecting the DNA, and the DNA begins to mutate, the methylation and the histone changes, and we can start seeing cellular changes occurring in both the breast and the ovary, which can actually turn into cancerous lesions. So basically, aging is a big problem, but if there's a hereditary component to breast cancer, like with the BRCAs, we really want to make sure that we screen that patient early and keep that screening happening on them so we can actually catch that breast cancer early. If we educate them properly on nutrition, exercise, and stress management, we can actually work to reduce the potential BRCA mutation. I wanted to give you an understanding of, okay, so how frequently does this stuff really happen? Are we like blowing smoke in the clouds? Well, take a look at the frequency of how mutations actually happen. Come on down. So we know that cardiac myopathies and arrhythmias, this particular gene, 26% of the population where this was tested on, and this actually was tested, I think it was, here it is, 11,874 patients. That's a really strong number reflective of the population. So if a person has this gene mutation occur, they're at greater risk for cardiac arrhythmia. Breast cancer, we've got the BRCAs. Cholesterol, we've got these two. 16% is pretty high. Cardiac arrhythmia, QT syndrome, 11%. And malignant hyperthermia, you don't hear about it a lot, but if you work in the OR and you're an anesthesiologist, this can be a bad thing and it can cause death. I actually worked PACU for a couple of years, and we actually had a 21-year-old male that came in for a simple surgical procedure and died on the table from malignant hyperthermia, unknown, no family history. So it is really important to understand, does anybody in your family have those problems? Pharmacogenetics, this is just a couple of mutations that we have to kind of be aware of. Notice the CYPs. CYP is all related to the cytochrome P450 family. And look at all of these. That's a whole bunch of genetics within the cytochrome P450 family. That's a bunch. Most of our medications are actually metabolized to cytochrome P450, so big problems. So when we're looking at genetic testing, what are we really looking for? And what I'm going to be talking about here is one of the reasons why some individuals who are going to be placed on depression medications or are non-responding to depression medications are being tested. We're looking to find out what kind of metabolizer that person is. So when we're looking at some of these genetic tests in relationship to drugs, we're trying to find out, are they an extensive metabolizer? Remember that there's a half-life to medications, and a half-life is on a generalized public sample. Well, if they're an extensive metabolizer, let's say we're dealing with 100 milligrams and 100 milligrams is metabolized in 6 hours. Well, if they're an extensive metabolizer, they may 100 milligrams in 6 hours. I'm sorry, I'm going to go back. Think of it this way. 100 milligrams in 6 hours, that half-life goes to 50. An extensive metabolizer, instead, they're at 75. So they metabolize more than the general population and the dosing requirements. So that means that we would need to take the dose down. Immediate metabolizers, this is important in relationship to immediate release medications. And again, we're looking at that half-life, how much medication are they going to get very quickly? And again, we may have to reduce the dose if we know they are that. Poor metabolizers. It takes them forever to metabolize a drug. It's like, oh my God, this is supposed to be out of their body in 12 hours and they still have half of it left in 36. We may have to go ahead and just extend the frequency or extend the amount of time between doses. And the super ultra rapid metabolizers, these are people who they take one dose of 5 milligrams of Valium and they're out for like 12 hours. They utilized every single ounce of that medication. So this is what we're learning and understanding. And this helps us understand dosages, types of medications, and the format of the medication we can give. And this is along the lines of personalized medicines. The IM and the PMs, so the IMs here, reduced effectiveness, unwanted side effects because the drug is in their body longer than it's supposed to be. Makes total complete sense to me. All right, depression and genetic testing. Here's where the research is in controversy. I did a lit search on this just before class yesterday. And what I found was conflicting information. But what I am finding is that the majority of the literature is saying that doing genetic testing, the pharmacogenetic testing prior to starting patients on depression medications is not efficacious. It doesn't need to be done. When they're saying it should be done is when your patient is failing pharmacotherapy. So they've failed at least one. So in other words, you started them on an SSRI, they're a generalized depression, nothing major, and the drug didn't work. And in actuality, the patient said they felt worse. You may change them to a second SSRI and they still aren't doing well. Then in that situation, it's okay to go ahead and get the pharmacogenetic testing to find out if they actually have a problem with metabolizing specific types of medications that are used to treat depression, bipolar, OCD disorders. The genetic testing that we would do is through the cytochrome P450 family, and it is these two cytochrome types that we're actually looking for. So the P2D6 and the P2C19. And the actual test itself is called a cytochrome P450, 2D6/2C19 genotyping. It takes about 10 to 14 days to get the results back, not counting weekends. And once you have it back, you will understand through the printout what medications the patient is able to metabolize properly and which ones the patient is not. As I had spoken of earlier, it is during our circadian rhythm that our body undergoes repair and restoration. And if we aren't able to repair and restore, the inflammation markers that our body produces during the day will continue to do destructive actions on the methylation and histone. And that is when we are going to begin developing disease processes and mutations of our cells. Some are going to mutate into the disease mode, such as the hypertrophy type disorders of the heart, and others could potentially deteriorate into cancers. But remember that our immune system also has to undergo repair too. And if we keep assaulting our immune system, it is going to break down and autoimmune disorders are going to develop. Last slide. So in conclusion, we are doing health promotion and prevention. We are not engaging in what we call a health educator role. We actually are the advocates. We are giving information, but we're advocating for that patient and working with that patient to build on their strength, provide them with knowledge, identify and work with their beliefs and attitudes, design and implement and monitor appropriate interventions. We're assessed on competencies to be able to do this, and we are completely involved in our patients' care. The evaluation that occurs as us as nurse practitioner is the outcome of how well we're able to keep them out of disease and their health markers. For health education, it's just about patient understanding. So as health promotion nurse practitioners, you're not just educating, you're educating and you're acting as a provider of promotion. This is your role. And this is what we are doing and what this course is going to help bid you to. All righty, questions, and I'm going to stop recording.